My name is Russ Jaffe. I'm an internist, I'm a biochemist, I'm a certified clinical nutritionist, and I maintain fellow status as a physician in the American Society for Clinical Pathology, the American College of Nutrition, the American College of Allergy, Asthma, and Immunology, the Federation of Clinical Immunology Societies, and I'm a fellow of the American Medical Laboratory Immunologists. I'm also an overseas fellow of the Royal Society of Medicine, and I'm a fellow of the Health Studies Collegium, founder and director of PERQUE Integrative Health, as well as ELISA Act Biotechnologies. The subject is a very important one, and I'd like to start at a high level. What are the thyroid-adrenal gland relationships? And while it's a bit mechanistic, you can think of your body as a vehicle, and as particularly a hybrid vehicle. And if you see the arrows and the diagram on the left, people have a brain that sends messages to their glands, including the thyroid gland in the neck, the thymus gland in the chest, the pancreas and adrenal glands in the abdomen, the ovaries and testes in the pelvis. And if you think by analogy, the thyroid is really your battery, and your adrenal gland is really your gas tank. And we'll come back to these analogies because in physiology, they're a little bit more elegant and complex. But to simplify the process, think of the thyroid gland as the battery and the adrenal gland as the gas tank. Now, what about the thyroid gland? Can it be overactive and hyper? Can it be underactive and hypo? Or can it just be in a mixed state of aggravation and what we call OI? On the left here you see an interesting Venn diagram, an overlap of circles that link low thyroid on the left, hypothyroidism in yellow, with hyperthyroidism in a kind of dark brown, and depression in a dark blue. And they overlap considerably. So people, for example, who have sleep disturbances or changes in appetite, they may have an overlap of hyperthyroidism and depression. And if you look on the left, you can see the overlap between depression and hypothyroidism, and people who have feelings of worthlessness, difficulty concentrating, feelings of unexplained sadness. I don't mean sadness from a real life event. I mean sadness from a memory or sadness that's out of proportion to the reality of the situation. In those situations, think about hypothyroidism. And if you were thinking about hypothyroidism, you'd want to ask about cold intolerance, about constipation, about whether they have dry, coarse skin, about whether they have lack of commitment or ambition. And if we go back to the right to the hyperthyroidism, if you're concerned about sleep disturbances and decreased appetite, be concerned about irritability or heat intolerance or palpitations and sweating or muscle weakness and tremors. And if you see those overlaps, go even one step further, because sometimes people cycle between hypothyroidism and hyperthyroidism. And functionally, clinically, they can actually have a combination of the two. And that's where you see all three circles overlapping: depression, hypothyroidism, and hyperthyroidism. And that's where unexplainable fatigue and unexplainable mood swings and unexplainable restlessness and weight changes can happen. If we look to the right, we see this is a large, not small problem, with over 60 million people in the United States having over or underactive thyroid. This is about half of the adults over 40, and most of it, much of it, at least half of it, undiagnosed. Now, what about the thyroid gland? If we look just at the thyroid gland, you can think of it as the metabolic governor. It's in charge of metabolism at a deep level in the same way that the battery provides the power for all the rest of the vehicle by that analogy. So thyroid problems can really wreak havoc. Mood changes, difficulty learning and remembering, heart rate variation, digestive problems, particularly constipation or alternating constipation and diarrhea, difficulty managing a healthy weight, unexplained muscle cramps, restless leg, and the like. In large part, not exclusively, and often in synergy with other deficits, can be a mark that the thyroid is out of balance. And as you see on the right, according to the National Women's Health Information Center, 1 in 8 women experience thyroid problems. Now, what are these thyroid interactions? What are these metabolic relationships or thyroid interactions with the body that are important? Well, if we look at this figure, starting in the top with the brain, the ability to learn, the ability for the brain to develop new brain cells. And by the way, everyone through their entire life can produce new brain cells when their metabolism is constructive and healthy. And moving to the right, the digestive tract. Healthy digestion depends upon healthy thyroid hormone provided in a balanced amount, neither too little nor too much. So if you have constipation, if you have problems with alternating digestive irregularity, or if you have a delicate belly, investigate the thyroid as part of the equation and as part of the solution. And in terms of liver and gallbladder function, the thyroid plays an important role in providing the stimulus to the nucleus of the cell to produce all of those protective and elective elements that the liver does for us, and also to produce the detoxifying bile that the gallbladder is supposed to put in the intestines, where toxins can be bound to fiber, and that fiber can remove from the body the toxins rather than allowing them to be reabsorbed. And if we move further around clockwise, lower right, we see the immune system, its function and its continuing resilience dependent upon just the right amount of thyroid hormone. Similarly, further clockwise, we see that glucose metabolism, the ability to maintain a healthy blood sugar, is in part, and in a significant part, related to having a healthy thyroid level. Further on, we see that bone metabolism, producing healthy bone, requires thyroid hormone for the osteoblasts to produce new hormone and the osteoclasts to produce, recycle the bone. And further around in the cardiovascular system, we find that the thyroid is important because your heart rate, in part, is determined by the thyroid. If you have too little, your pulse might be too low. If you have too much, your pulse might be too high, not because of exercise adequacy or inadequacy, although that is important, but strictly because the thyroid itself plays a role in setting the background energy, the background rate at which the heart operates. So the thyroid interacts with the entire body in important ways, and these metabolic relationships are worth keeping in mind as you see the people you care for and practice to bring to health. Now, if we look from brain to thyroid to cell receptors, we find in the diagram on the right and represented on the left in this flowchart that deep in the brain is a hypothalamus, which connects through the thalamus to the pituitary. And the deep brain brings the message to the gland, to the pituitary master gland, to release thyroid stimulating hormone, what's called TSH, which then goes to the gland in the neck, to the thyroid gland and the receptors. The TSH induces the production of thyroxine, assuming that there's enough tyrosine and iodine, assuming that the enzymes are in the right conformation. And then at the active cell receptor, both in the gland and throughout the body, the T4 is turned into the active thyroid hormone. And while in earlier studies and in most reports, the thyroid gland is considered to have 80% T4 and 20% T3, more elegant studies have shown that T4 really is a precursor. It's not just 1/4 as active, it's much less active than T3, and when we try to measure T4, in most studies, a little bit of T3 creeps in and actually makes us think that the T4 is more active functionally than it really is. So from the hypothalamus that releases the TSH releasing hormone, as you see on the top left, to the gland, the pituitary master gland that releases the thyroid stimulating hormone, and that goes to the thyroid gland and cell receptors to produce first the thyroxine T4 and then convert by reduction of 1-iodine to triiodothyronine, the T3, the active thyroid hormone. the more active thyroid hormone. Now let's look at the pituitary thyroid adrenal relationships and hormone balance in a diagram, and we'll see how elegant and complex are these feedback biological systems and why it's so important. So on the left, we have the HPA axis. That's the hypothalamic pituitary adrenal axis. And on the right, we have the HPT axis, the hypothalamic pituitary thyroid axis. So it actually turns out there are a number of these, quote, axes or interactive relationships. And if we start in the middle and then work to either side, we find that stress, the internal perception of psychological distress, of psychological trauma, electromagnetic signals, infectious or allergic stresses, dysbiosis and xenobiotic toxin stresses, any and all of these can influence the deep brain, and as you see by the arrows, both the left HPA axis and the right HPT axis. Well, now let's follow on the left first, and then we'll come back to the right. So if we follow the more familiar HPA, hypothalamic pituitary adrenal axis, you see that at the deep brain, the hypothalamus, there's a release of corticotropin releasing hormone, a general hormone that stimulates the pituitary. And the biochemistry and physiology is here very interesting because the body isolates the pituitary gland and then the brain literally drips the releasing hormone or releasing factor chemicals down the stalk of the pituitary in order to stimulate it. So the hypothalamus can release too little corticotropin releasing hormone, that would be the hypo on the left, or too much, that would be the hyper on the right. Whatever stimulus the pituitary gland gets, it tries to respond to. And so the pituitary, in response to the corticotropin releasing hormone stimulus, releases ACTH, adrenocorticotrophic hormone. Stimulate the cortex of the adrenal to release hormones. And if you have too little ACTH, you get little adrenal response in general. And if you have too much ACTH, you get an over response by the adrenal in general. And it is the cortex, not the medulla. It's the outside, if you will, not the inside of the gland that's involved here. And so the cortex of the adrenal, in response to this ACTH, releases what are called glucocorticoids, that is, hormones that influence blood sugar, particularly cortisol. And in addition, neurotransmitters or catecholamines, epinephrine and norepinephrine, but also other hormones like aldosterone that influence salt and water balance. So the adrenals dramatically influence blood sugar, our neurochemical responsiveness, our relaxation or stress perception level, as well as our water-salt balance. So kind of important. And as I said, if there's too little ACTH, there's too little of those hormones. And if there's too much ACTH, there's too much. But right in the middle is where we have a balance of cortisol and the hormones that balance cortisol so that blood sugar is kept in a healthy level, that neurotransmitters like epinephrine and norepinephrine get us up, but not too much, and they stimulate us, but not too often. And aldosterone is there to make sure we have a right salt-water balance, but not too much volume or too little, not too much salt or too little, because that can alter blood pressure in profound ways. And now, as you see, the corticotropin releasing hormone also influences the right. You see the arrows going from left to right. And if you look down at the bottom, you see a set of arrows that the glucocorticoids interact with the thyroid. So this is why we talk about pituitary, adrenal, thyroid interactions. And now let's go back to the upper right, the HPT, or hypothalamic pituitary thyroid axis, starting at the deep brain at the hypothalamic level, to release thyroid releasing hormone, which stimulates the pituitary to release TSH, the actual thyroid stimulating hormone after the thyroid releasing hormone. And the thyroid then releases T4, which then at the cell receptor level is converted in healthy people to T3, the arrow that goes straight down. But in people that have problems with metabolic acidosis and other nutritional and physiologic deficits and imbalances, instead of pulling the correct iodine off, conformational shifts may induce reverse T3, that is a competitive inhibitor of active T3. And this is actually a backup system for the body. If the body senses too much T3, it can in some cases reverse the T3 production to downregulate that. So there is a healthier side to this, but there's also an unhealthier side. Reverse T3 normally forms when you have other imbalances like metabolic acidosis and deficits of the minerals that correct the conformation of the hormone. This is what happens when you have too much oxidative stress and too little antioxidants to set a healthy low redox potential and the like. Bit complex, we'll get into the details later. So the thyroid releases T4 that at the receptor is deiodinated to T3 in the healthy state, and in the less healthy state sometimes to a competitive inhibitor called reverse T3, and that's important to know in some cases. And if you want to know what all these acronyms or code words are in the lower right, you can come back to the archive and review what the terminology represents. Now let's look at the thyroid gland in normal functioning, in healthier functioning. The deep brain sends the thyroid-releasing hormone stimulus to the pituitary gland. That then sends the TSH stimulus to the thyroid. Notice the arrow coming down from the blue pituitary in this figure and towards the kind of pinkish pretty gland, the TSH stimulation. The thyroid releases the hormones, the T4 that gets converted to T3, and the free hormone in healthy people, not the bound or the total, but only the free hormone is active. The free hormone goes back to the brain, back to the pituitary, and actually back even to the hypothalamus, and says, thank you, we have enough, you don't need to stimulate the gland anymore. And so when that inhibition is lost, there are problems. And if the gland doesn't respond properly, there are problems. So not the total hormone, that is easier to measure, but the free hormone is what we want to know about if we want to be more accurate, more evidence-based, more scientific in our understanding of the thyroid and its relationship to the pituitary and even to the thalamic control structures when necessary. Let's look again at this picture to reinforce the message in regard to the thyroid gland and the T4 pre or pro hormone and the T3, the much more active thyroid hormone. Here you see that in the thyroid gland, in this diagram starting at the upper right, you have the blood thyroid barrier, and it's very important that that be healthy and repaired by an active immune system that is able to do both defense and repair. It's also important that the blood have a certain amount of iodine. That I minus is the iodide, actually iodine is the I2, iodide is the charged molecule. The iodide must come into the gland through the sodium iodine symporter, that is basically iodine comes in and sodium gets transported in correlation with that to keep the charges equal. And then this iodine, once it's inside the cell, can be acted on with the stimulus from the nucleus through the endoplasmic reticulum to the thyroglobulin secretion. That thyroglobulin secretion induces the exocytosis, that is the release of the product, the thyroglobulin, after being pushed out. We have the pendrin, which converts the iodide to iodine, and there iodination, as you see in the lower left, occurs. Iodination means we add iodine to the tyrosine that's in this thyroglobulin, and after that conjugation, after that transfer of iodine to the tyrosine, then there's endocytosis. It's pulled back into a little vesicle. Proteolysis occurs, that is the protein is degraded, and what you're left with is the thyroxine, and at the receptor, the triiodothyronine. The thyroxine is the T4, the triiodothyronine is the T3. And the T4 should be released back into the blood through the healthy blood thyroid barrier. And the triiodothyronine, acted at the receptor, can also be released into the body. Now the T4, the thyroxine, will be converted to T3 peripherally at the receptors, and so it really is the triiodothyronine, the T3, the free T3, that is the active, and most important hormone to measure. And usually you want to measure both free T3 and free T4, as well as TSH, to understand the relationships. Moving on, by diagram, we reinforce the thyroid hormone stimuli in the following way. Any external stimulus, cold, stress of any kind, is perceived by the body, and it's the perception that matters, not the external stimulus, but how we recognize, how we respond to that stimulus inside. That's the real stressor. Any stressor gets the attention of the hypothalamus. And in this case, the hypothalamus releases thyroid-stimulating hormone-releasing hormone, TSHRH, that tells the pituitary, now's the time to release TSH, that tells the thyroid gland that it's time to release thyroid hormone to go to the body to increase the metabolic rate, which then will increase the body temperature, and here by analogy, if cold is the stressor, the perceptions influence the feedback, so that the hypothalamus now says, oh yes, I've warmed up inside, I don't have to keep stimulating the pituitary. Any stimulus, any stressor, will have the same kind of loop in healthy people, from the brain to the master gland to the peripheral gland to the whole body, and then feedback that says, thank you, you've done your job, please stop. Now let's get into the dysregulation, first with hypothyroidism. 20 million people in the United States, about half of the people with hypothyroidism at any one moment, are undiagnosed. So there's a lot of people walking around whose got up and went, and they don't know why they're really hypothyroid, but they haven't been properly diagnosed. And here there is primary as well as secondary hypothyroidism. So if we start on the right with the image, primary hypothyroidism is where the thyroid can't or won't or doesn't produce a healthy amount of hormones, despite how much stimulation the pituitary brings it. So in primary hypothyroidism, you'll have a high TSH, but you'll have disproportionately low thyroid hormone released. In essence, you're overstimulating the gland, but it's underfunctioning, and you're getting a diminished, progressively diminished response. Now, secondary hypothyroidism is a different story. Here, the thyroid isn't being stimulated by the pituitary to produce hormones. So sometimes people have a low thyroid, even though their thyroid is waiting for the message to get going, but the get going message, the TSH message, doesn't come. So you can have high TSH and low free T3 and or free T4, and that's primary hypothyroidism. Or you can have low TSH and low hormones, low T3 and T4, the free hormones, because you're not getting enough stimulus from the pituitary in the brain. So typical hypothyroidism, if we look on the left, has a low T3 and a high TSH. A decreased metabolic rate is one of the characteristics of hypothyroidism. Easy weight gain and difficulty losing weight is part of the equation. And a general, not just lack of energy, but a lack of optimism, a lack of passion, a lack of interest in life. So if you know of anyone who is not having a good life but doesn't seem to care, check their thyroid. That might be the source and the solution to the problem. Now, what about T3 metabolic actions? There are possible sites of defective thyroid hormone metabolism, and these occur at the cell membranes. So we have the T4 and some T3 in circulation. Then there's the thyroid hormone transporter, And the T3, the really active, helpful T3 that gets into the cell, usually converted from T4 to T3 at the cell membrane, goes to the nucleus and there activates specific parts of the DNA to produce messenger RNA that's transcribed and produced into protein for the benefit of the cell. So T3 is essential to activate the nucleus to make the proteins that life depends on throughout the body. Now let's go more deeply into hypothyroidism. My suggestion in terms of healthy people is that the TSH above 2.5 microunits per ml, that a TSH above 2.5 is too high. And here I'm going to show you a figure that in 1998 was state-of-the-art, and then I'm going to correct it to what I think in 2012 is state of the evidence and art. And in essence, the mechanistic understanding we had back in the 1990s compared to a much more functional, much more dynamic and predictive approach that we have today. Now in both cases, in the presence of normal T4 levels, TSH is higher than it should be. This is primary hypothyroidism. After 2 tests are taken 6 weeks apart. Now that applies to adults. In children, I believe that if children have a high TSH, they should be given desiccated thyroid. After the second test is drawn, because you have the results of the first test showing a high TSH and a need, and while you're waiting for that second TSH value to come back to confirm that it's elevated, I would start children on a low dose, maybe 1/4 grain of desiccated thyroid, or 1/4 of the usual dose of T3, a physiologic amount of the hormone, so that we don't wait too long to confirm what we kind of already know, that can harm particularly children who are growing rapidly. If you look at the left, where the TSH is elevated, and notice here that back in 1998, we thought the TSH should be above 10 to be surely elevated, and 5 to 10 was elevated, but we weren't too sure. I'm suggesting that above 2.5, you should be functionally concerned. However you call it, maybe a form fruste of the syndrome, or maybe an incomplete expression, above 2.5 TSH is above healthy levels in our recommendation and assessment. If TSH is consistently up, you do want to check for anti-thyroid antibodies. If they're positive, then you would put people on thyroid hormone and stimulate their repair. My addition about the stimulated the repair so that you can correct the blood thyroid barrier and then have a more efficient feedback between the active hormone, the pituitary control gland, and the stimulating hormone, the TSH. If antibodies are negative, then the symptoms could be related to hypothyroidism, primary or secondary. Since the TSH is elevated, we would say it's primary hypothyroidism, and we would start therapy. And I would start therapy while you're waiting for the second test to come back. Now, let's say the person doesn't have symptoms, but they have a high TSH. Or let's say that the TSH is a little elevated. Back in the 1998, 5 to 10 was considered to be borderline. Now I am suggesting that above 2.5 is reason for concern. Even at a borderline level, the doctors then wanted to check antibodies, and if they were positive, progress to therapy. And if antibodies were negative in adults, they recommended observing and retesting every 6 months. And now I would change that to recommending starting people on an iodine and iodide enriched diet to make sure that they have enough of the iodine and iodide precursors. I would start people on healthy thyroid. I tend to start with desiccated thyroid at 1/2 grain for adults and 1/4 grain for children. Children need proportionately more than adults. And then I would see functionally how people respond, and I might raise that healthy thyroid intake, still within physiologic ranges, if I got some but not complete response. And of course I would be guided by the interaction of the pituitary with the thyroid, the TSH levels, and I would be guided by the free T3, free T4 levels to help me understand whether there was any problem, and if so, whether there was a problem in the gland, or there was a problem in the pituitary gland, or in the thyroid gland, or perhaps in the periphery, where the conversion of T4 to T3 takes. So the more we get into these questions, the more elegant they become, and I believe we can walk through them in a way that makes them accessible to you in practice and to understand at an elegant level what is going on. Now, hyperthyroidism means too much free hormone. It's the other side of hypothyroidism, or more typical thyroid dysfunction. If too much hormone is produced and the feedback doesn't slow down the production of that hormone, we can be overstimulated. If we're overstimulated, our heart can race, we can be more anxious than we otherwise would be, and these can be signs of excess thyroid hormone. So hyperthyroidism is also important. It means too much free thyroid hormone and poor feedback inhibition. It means an increased basal metabolic rate, the opposite of hypothyroidism. It means that there may be palpitations or heat intolerance, or the heart rate, the pulse may increase. There tends to be warm, moist skin. Other names for this include Graves' disease, toxic nodular goiter, and in a more advanced form, Hashimoto's thyroiditis, which can have an overactive phase and then an exhausted phase as well. The classic treatment has been radioactive iodine and antithyroid drugs to block hormone production, and we now suggest that that is not the current state of the art, that we want to approach physiologically the solution by making sure the diet has enough iodine and iodide, by making sure that the antioxidants have set a healthy low redox potential. That means scorbate based on C-cleanse or personalized adequate intake of antioxidants like ascorbate, so that the body will produce the healthy T3 and not the competitive reverse T3. Now, if we look at another aspect of thyroid dysfunction, the autoimmune condition of Hashimoto's thyroiditis, it is an AI or autoimmune condition where the gland basically is attacked by the body because the blood-thyroid barrier has opened up for lack of repair, for being overly stressed, and a DTH, or delayed hypersensitivity, delayed type hypersensitivity, emerges. Antibodies to the thyroid gland are produced inside the gland. That's part of how we know that the blood-thyroid barrier has been breached, and actually the antibodies are part of the body's effort to repair the gland as well as the blood-thyroid barrier. So in Hashimoto's thyroiditis, the blood-thyroid barrier is open, and when one blood-thyroid or when one blood-gland barrier is too permeable or open, think about other parts of the body also being too permeable. There is a genetic component, about 8%, but lifestyle choices determine 92% of Hashimoto's thyroiditis. Now, in terms of Hashimoto's and Graves', the interaction of these delayed type hypersensitivity conditions, in Hashimoto's we tend to focus more on the autoimmunity side, and in Graves' disease we tend to focus more on the excess of hormone. And in my clinical experience, there's often a continuum and an overlap between these conditions, but they both represent, in their earlier phases, too much hormone for what the body needs and a lack of proper feedback inhibition, and in both cases represent intolerances that need to be repaired. Hashimoto's thyroiditis occurs in about 3.5 out of every 1,000 people in any given year in women, and about 0.8 per 1,000 per year in men. Aggregated over a lifetime, that's a lot of people. Tissues are too permeable. There's an accumulated repair deficit. Digestive remnants are occupying the immune system. The immune system is preoccupied with too much defense work and is not properly repairing the thyroid and possibly the rest of the body as well. So their increase in defense workload translates into less ability to repair and keep a healthy blood-gland relationship or blood-gland barrier. In terms of Hashimoto's thyroiditis, there are tests to measure to get better outcomes, and here, cell-mediated functional tests for T cell activation, because Hashimoto's thyroiditis is only partly an antibody problem. It is mostly a T cell excess problem or T cell imbalance. And LRA by ELISA ACT tests are functional lymphocyte response assays that measure T cell and B cell responses ex vivo, just as they occur in the body. Now, antibody serology responses are the usual way of monitoring antithyroid microsomal antibody, antithyroid globulin antibody, antithyroid receptor antibodies. These can all be measured, and we suggest that when they are elevated, following the LRA by ELISA ACT test results and plan, will predictably and predictively lower those antibody responses in proportion to the completion of repair. So you can monitor outcomes with the antibodies, but the antibodies themselves don't tell you function. They do tell you need. Let's look at a typical case success. Leslie was a 30-year-old woman diagnosed with late-phase Hashimoto's thyroiditis. She had signs and symptoms of bloating, joint pain, weight gain, and fatigue. The initial therapy was Synthroid T4 and then Euthyrox, which was a more natural thyroid without much change. The integrative intervention was the LRA by ELISA ACT test with the Alkaline Way plan. And in this case, the individual had just 2 strong and 7 moderate reactions, including red grapes but not green grapes, egg whites but not egg yolks, benzaldehyde, and aspirin. And if something unusual statistically or something uncommon is a cause of immune burden for the individual, it's what the individual's immune burden is like that matters. And that's why it's been so hard in the past, and now why it's so straightforward using LRA by ELISA ACT tests to determine what the individual responds to, what they need to substitute, and we can help, of course, in our report with hidden places where things could be found and exposed to, and how to substitute so that it's a window of opportunity to repair rather than a sense of deprivation for things we like. In Leslie's case, the clinical outcome was that after 2 weeks or so of substitution in the alkaline diet, the energy levels increased, thyroid need drastically reduced, and she continues doing better at 5+ years, taking no supplemental thyroid, but following her LRA by ELISA ACT program, which she repeats every 6 months. And when asymptomatic for several years, that can be repeated maybe once a year, not every 6 months. So autoimmune self-attacks occur. Multiple sites are likely. If you find autoimmunity in the thyroid, look for autoimmunity in the rest of the body. You will be rewarded and you will find it. Antibodies, however, are produced inside the gland as a sign of the deficit. You want to breach the blood-thyroid barrier and correct it. You want to recognize that breach and correct it. The high permeability is a problem. The low repair is the more fundamental problem. And while there are genetic, it's really the epigenetic, it's really the environmental influences that are most important, and these, fortunately, are ones that we can influence, and with the help of the LRA by ELISA ACT tests and the Alkaline Way WellGuard program, people can have better outcomes and more predictable results. So thyroiditis in integrated practice starts with a physiology-first approach, if you will, a rethinking, so that we look at functional immune responses through the LRA by ELISA ACT tests. We look at hormone and hormone mimic functions because environmental hormone mimics can confuse the body and contribute to these problems. We look at neurochemical balance as well as epigenetic choices and attitudes, mindfulness, and we interact at the important level of daily choices and habits, at daily attitudes and practices to improve upon them to restore a healthy balance, a healthy physiology. Now, low adrenals, low thyroid, or both, and let's look at what from an observational standpoint might be useful information. If we start here with body type, people with adrenal dysfunction tend to be thin and can't gain weight. If you have both sides, you may be able to gain easily, but the fat tends to go to hips and tummy and very hard to lose. And the thyroid, if you look at the right, low thyroid is associated with easy weight gain, generalized or global weight gain, and that it's hard to get back to a healthy weight balance. The face in terms of its shape, the eyes and cheeks tend to be sunken when the adrenals are the issue. When the thyroid is the issue, more likely to be full and kind of puffy around the eyes because of the tissue permeability issues. In terms of eyebrows, with the adrenal problems, they tend to be really full. And on the far right, with the thyroid, they tend to be sparse, particularly at the outer 1/3. So someone who is losing their eyebrows in the outer 1/3, in my clinical experience, should be checked for thyroid function. In terms of the tissue around the eyes, with the adrenal problems, they tend to have a sunken appearance. And with the thyroid problems, they tend to be puffy, as we said, often with bags around the eyes. In terms of facial coloring, the tendency is towards being kind of a pallor or a light, a lack of vitality in the skin, and often with a pigmentation that's hard to explain, whereas thyroid issues tend to go towards a ruddy or rosy complexion, particularly around the mouth. In terms of hair quality, with the adrenals, the hair tends to be thin and wispy. On the dry side, falls out easily, sparse on the forearms and lower legs, whereas with the thyroid problems, they tend to be coarse and may become wavy or curly, or even change in color. So observation is a really powerful tool in helping us decide where issues need to be further investigated. Now, the hormonal and neurochemical systems here in regard to functional tests, when anyone has what might be a thyroid or adrenal problem, I recommend salivary testing for DHEA and free cortisol at 4 different times during the day. I also recommend and only use the free T3, free T4, and TSH, and I may check antibodies to monitor status. I may look in the urine for estrogen metabolites, toxins like PCBs, because these are hormone disruptors and in complex cases can play important roles. Now let's look at the PERQUE Adrenal Distress Guard Natural Adrenal Support and Thyroid Protection. So even though the name PERQUE Adrenal Distress Guard says adrenals, when the adrenals are happier, the thyroid is as well, and vice versa. There's a tropho-restorative formula, safer relief from high-tech living, repair of the hypothalamic pituitary adrenal axis naturally, and restorative sleep. Cortisol DHEA rhythm changes for the better when you follow the support in this natural, physiologic, or tropho-restorative, that is glandular restoring way. And it's a unique formula. There is no other formula that we know of that is entirely supportive of the gland and helps rebalance it rather than force or overstimulate the gland. Let's look at results of a study. Here we took a group of people and just asked them to take PERQUE Adrenal Distress Guard for 6 weeks, and we measured their level of hormone cortisol response. And you see before that people tended to have lower and less healthy cortisol levels and not as good rhythm, that is, the lines tended to be straighter. Whereas after just 6 weeks, the basal cortisol was nearer an optimum level. This is significant at the less than 0.001 level. And throughout the day, there was better rhythm. And you can see the details in terms of mean and standard deviation in the upper right. Here's an example of an adrenal fatigue success. A 48-year-old woman was diagnosed with hypothyroidism and underlying adrenal imbalance. She had extreme fatigue, lack of restorative sleep, 2-hour naps during the day, 8 to 10 hours at night, muscle aches, and weight gain. The initial therapy was Natrothyroid, a natural thyroid support for 3 months. That didn't work. Then Armour Thyroid for 6 months, and that didn't work. There was no change, essentially, clinically. Person did other therapies, including massage and Reiki, but the problems continued. The integrative integration was the LRA by ELISA ACT tests with an Alkaline Way plan and PERQUE supplements. This individual had just 2 strong and 9 moderate reactions, but notice that while red grapes and aluminum and white potato were reactive, so were methylene dichloride and organophosphates, pesticides, and beet sugar specifically. So when we treat individuals in a more personal way through the LRA by ELISA Act tests and the Alkaline Way plan, with targeted PERQUE full disclosure supplements where all components are active and nothing is inert, better results follow. So this individual used PERQUE Adrenal Distress Guard, PERQUE Life Guard capsules, PERQUE Potent C Guard powder, PERQUE B12 Guard, as well as PERQUE Repair Guard, and did 2 30-day PERQUE Integrative Health Detox kits, so 2 cycles of the PERQUE Detox Kit program. And the clinical outcome after 16 months was dramatic improvement in quality of sleep, increased energy, was able to complete a marathon and I believe also a half marathon with ease, and on no thyroid medication, this person was doing better, and on no adrenal medication per se, except the tropho-restorative benefit of the PERQUE Adrenal Distress, needed now at lower levels, but still needed for support. So when our immune system is tolerant, immune responses prevent allergies, there are no allergies. The immune system, when tolerant, neutralizes infections and allergens, repairs from daily damage, and deletes abnormal cancer cells. White blood cells respond to any foreign invasion. Defense comes first, repair follows. And if defense preoccupies, then repair and identifying abnormal cells can be deferred with the emergence of chronic or degenerative or autoimmune or increased cancer risk. So how do we rehab or rehabilitate the immune system? First, we want to restore first responder cells. We want to neutralize or recycle allergens, not have them provoke distress and burden us. We want to stimulate repair by providing the essential nutrients and nutritives, because only after defense is done does the body get to do the repair work that's needed. And the functional solution for all of this is the LRA by ELISA Act tests and treatment plans to find immune overload causes and reverse deficits. Now, how about the overloaded immune system? Here the digestive system takes a hit, more susceptible to thyroid and adrenal imbalance and many other hormone imbalances, and inflammation, the common link to almost all chronic, degenerative, and persisting illness, which is really repair deficits. Inflammation persists in excess, and we at the Health Studies Collegium have rethought inflammation at a more fundamental level, and we recognize it as cumulative repair deficits. And you're welcome to look into the references provided and into our websites for further information. So thyroid and adrenal support using physiology first, the alkaline way. Tolerance can be lost. We can become hospitable. There can be an overload of foreign reactive antigens. And when that happens, we're hospitable to chronic infections, because infectious and non-infectious materials are equally foreign to the IDRS, the immune defense and repair system. And if the immune system is preoccupied, say, with non-infectious digestive remnants, it's less able to defend us against actual invasive infections. And as we've talked about extensively in other webinars, and I welcome you to look at those, according to the classic Gell and Klune's nomenclature, there are 4 aspects of immune responses. The type 1 shown in red are the immediate acute allergies, and that's what most people think about. The reactions that occur within seconds to minutes after exposure. And then there are the types 2, 3, and 4, reactive antibodies, but not neutralizing helpful antibodies, or immune complexes, or T-cell, direct cell-mediated responses. And fortunately, the LRA by ELISA Act is ex vivo and measures all types 2, 3, and 4 reactive problems without being confused by neutralizing and helpful antibodies that are measured in the static, much less helpful IgG antibody tests. So the state of the art is LRA by ELISA Act functional tests. They're more predictive and helpful. We do not recommend the static, the antibody IgG tests that measure both helpful and harmful antibodies and are unable to distinguish between them. So allergens provoke symptoms, and when allergens are increasing the defense workload, repair is deferred. We become hospitable hosts to pathogens, and we recommend the LRA by ELISA ACT tests as functional tests to identify the causes of immune burdens. Just a 1 ounce blood sample can now be used for up to 490 LRA ex vivo tests, measuring the widest array of foods, additives, and preservatives, or environmental chemicals, toxic minerals, medications, molds, danders, hair, and feathers, and herbs. And small molecules can, through a mechanism called haptenic reaction, that is, small molecules can bind to bigger proteins in the body, render those foreign to the body, and we make immune responses and reactions to those complexes. So there is a bit of complexity here, but if you want the most comprehensive, if you want the most functional, if you want the most predictive and well-validated, you would want LRA by ELISA ACT tests to measure delayed hypersensitivities in all categories. And then we have over 60,000 cases in our experience database. We can match up your individual, including their health appraisal questionnaire, to provide them the most individualized and personalized outcome program. So LRA by ELISA ACT tests identify substances that are burdening the immune system. We want to substitute to restore digestive tolerance. We want to recognize that strongly reactive items need to be substituted for 6 months and moderately reactive items for 3 months. And when people make their best efforts to be consistent, the body can soak up and neutralize the little bit of remainder. There is some threshold that the body can recycle itself without difficulty, and as long as we lower the load on the immune system below that threshold, then repair can reoccur. So lymphocyte response assays by ELISA ACT, ex vivo, accurate, functional, comprehensive, and proven clinical outcomes. Find the causes of all delayed allergies with accurate and comprehensive delayed allergy tests and recommendations for management. We put it on the line. You and your clients get the results. The test works in the following way. The whole blood is sent to us. It must be kept cold so that the cells are kind of put in suspended animation. And in the lab, we then gently spin so the red cells are removed, and the cell or lymphocyte-rich plasma is then used in the test. We have created a novel microtiter plate. Think of a series of dishes, each one of which is coated with a different substance. And when the cell lymphocyte-rich plasma is allowed to interact with each of those wells or each of those dishes at about body temperature for 3 hours, the cells react just as they do in the body, and if they're programmed against that substance, if they've learned to react against that substance when in the body, we will see it in the laboratory, and the technician then measures it immediately upon incubation. Results are clear between non-reactive and reactive cells. The non-reactive cells you see on the left, the reactive cells you see on the right, and it's that difference that we measure in the laboratory. We have successful outcomes that often overlap with thyroid problems, including success in fibromyalgia, where in a 6-month study we were able to achieve a 50% reduction in pain, a 70% reduction in depression, 50% improvement in energy, and 30% less stiffness. And in 5 and 10-year follow-ups, we find these people continuing to do well at lower cost and with better function. Thyroiditis does overlap with other autoimmune conditions, including diabetes, and we have the most successful outcome study, pilot study in diabetes. Tolerance loss in diabetes is associated with foreign antigen exposure. And in the type 2 diabetes study, we saw a 13% reduction in hemoglobin A1C, and in the type 1 diabetic study, we saw a 46% reduction in hemoglobin A1C. And while insulin function improved in the type 1s, to our pleasant surprise, in the type 2 diabetics, there was an 18% insulin reduction, which means less insulin was able to be more functional, and that's what we want. So with over 60,000 cases and over 30 years of experience, with patient and practitioner testimonials, and with outcome studies to support this novel approach, we recommend LRA by ELISA ACT tests for those with any and all of these autoimmune or self-attacking problems. So, the alkaline way is the summary of what we recommend. Evoking human healing responses is what our rethinking has led us to, and the outcomes are so exciting that we want to share that with you. The WellGuard program is the synthesis of this physiology-first approach to restore competences, to enhance immune tolerance, neurohormonal balance, digestive and detoxification function concurrently and intimately. It's a three-step approach. Step 1 is to determine the status using a health appraisal questionnaire. Step 2 is the LRA by ELISA ACT test to find these hidden burdens and allergens. And Step 3 is the personalized PERQUE supplementation program. Eat what you can digest, assimilate and eliminate within healthy balance and homeostasis. Eat what you can digest, assimilate and eliminate within healthy immune tolerance. An alkaline diet saves lives, and when combined with the LRA by ELISA ACT tests, restores years of quality life to the individual. So we want to, in regard to the immune system, enhance the function and stop the burden. We want to stop people from being hospitable to pathogens. We want to stop allergens from provoking symptoms. We want to repair and stop the repair deficit due to the excess defense load. So if you want a functional approach, if you want a clinically validated and evidence-based approach, LRA by ELISA ACT tests and functional tests identify the causes of immune overload and are recommended. The Alkaline Way benefits include neutralizing excess cell acids to sustain health and preserve nutrients inside the cell. Alkaline Way benefits include digestive and immune system tolerance, that's proactive prevention rather than reactive problems. And Alkaline Way benefits include regaining tolerance to lose reactivities so that active repair and cancer surveillance can be restored. It is a choice. Part of this in the Alkaline Way is the first urine pH after 6 or more hours of rest. And you want it to be in the healthy green zone, 6.5 to 7.5. And please look at our archived webinars for more details on this first urine pH after rest. Here's a chart that we recommend people to keep for themselves, noting the date and the time, the pH level, and how they feel. And people will often come in and report to you that when they're more acidic, they're more symptomatic, and they're less hopeful, they're less productive. But when they're more alkaline, they're more productive and more hopeful. The test is done with a standard but specialized pH test paper with a range of 5.5 to 8. Only that pH paper is dynamic enough for this use. And after more than 6 hours of rest, you wet 2 to 3 inches of the strip of the test tape with that first AM after rest, could be usually in the morning. And if the color remains yellow, you're too acid. If the color turns green, you're in the goal healthier state. And if it's blue, you're too alkaline. Neither extreme is desired. The middle path is preferred. Here we have the food and chemical effects on acid-alkaline body chemistry. Foods can make you more alkaline and healthier. Foods can add to your acid load and deplete you. We want you to have mostly alkaline-forming foods to neutralize cell metabolic acids, and then a little bit of the acid-forming foods, but in proper balance. We also have predictive biomarkers that are specific as well as global. For inflammation and repair deficit, we recommend measuring the HSCRP, the high sensitivity CRP, and it should be less than 0.5. We recommend detoxification and methylation with homocysteine, and it should be less than 6 micromoles per liter. We recommend measuring oxidation and antioxidant status using oxidized HDL, LDL, and adeoxoguanine, and they should be essentially non-detectable. We recommend measuring sugar, insulin, and energy through the hemoglobin A1C, and it should be less than 6 milligrams per deciliter. And we recommend checking the acid-alkaline metabolic status with that first morning or first urine after rest, and the pH range should be 6.5 to 7.5. So the alkaline way can be monitored through these predictive biomarkers to restore, repair, and defend the body. The alkaline way, evoking human healing responses, in an evidence-based and truly scientific way. Health is more than the absence of disease. Health is the fullest physical, mental, and spiritual expression attainable by each individual. And here we're really standing on strong shoulders. We're paraphrasing Hippocrates and Galen and Huang Ti, as well as the World Health Organization.